Hello everyone, my name is Eleanor Burgess and I'll share our paper today, Care Frictions, a Critical Reframing of Patient Noncompliance in Health Technology Design. This was truly a collaborative effort with my co-first author, Elizabeth Kazunas and Maya Jacobs. Many of you have heard the term non-compliant. Generally, it is a label noted by a medical professional where they have requested that a person managing their care do a certain task, and for many potential reasons, that task was not completed. On one hand, healthcare clinicians may be concerned about negative health outcomes for the patient. On the other hand, patients can be incredibly frustrated that the clinician isn't listening to them. They can be deeply frightened, devastated by their illness, or ashamed of not being able to afford their care. The term non-compliant obfuscates the complexities of what's actually happening in these situations of tension and friction. Therefore, in this work, we push against and seek to reframe the term non-compliant. We urge people to pause and look deeper at these moments. Drawing inspiration from anthropologist and STS scholar Anna Lowenhout-Singh's work on the concept of friction, we introduced the term care frictions as a sensitizing concept that characterizes the types of sticky engagements found in health contexts where different stakeholder goals and social worlds don't neatly align but actively conflict with one another. Let's look under the hood here at a couple examples of these care frictions across our prior research. This paper represents a comparative analysis of 3 qualitative patient work research projects. We then moved to an individualizing comparison process, as originally characterized by Tilly. We returned to data we had previously published, viewing it anew from an analytic distance and with a comparative perspective. We realized, for instance, that none of the co-authors alone could have written this paper about non-idealized behaviors because it was often more of a peripheral finding. However, when we combined data, strong themes emerge regarding the significance of these forms of patient work. For today's talk, I'll share examples from the chronic kidney disease and community behavioral health contexts. In the context of chronic kidney disease in the United Kingdom, once a person's kidney function starts to show a need for dialysis, clinicians expect that patients will read information and discuss in order to make a series of treatment decisions with major life implications. However, the emotional nature of this health information, along with life changes to be made, can easily be overwhelming. One patient shared her thoughts about why she doesn't want to read further medical information. I don't think I'd want the responsibility. I just wouldn't be able to deal with. I think it would bring me home too much. If I were looking at pictures of kidneys and things, it would make it more real than it actually is. Faced with major decisions about their future involving complicated medical knowledge, some people may avoid information or ask their clinicians to make treatment decisions for them. And in the context of behavioral health in an under-resourced community in the US Midwest, nurses and doctors often lamented people's failure to take medications as prescribed, even though they knew many residents routinely dealt with issues of food scarcity and housing insecurity. For these residents, routinely purchasing medication to keep their depression or anxiety in check was often an impossible goal. When people could afford to fill their prescription, they would often stretch their supply by cutting pills in half, taking a dose every other day, or relying on family and friends to share their pills. A resident who was struggling with depression and also on unemployment shared she saw herself as a patient who tried, explaining, "Sometimes I don't take my pills every day. I'll take 1, maybe 2. I don't take 3 if I don't need them because my environment is quiet. But if I have to step outside that house, I never know what I'm going to run into. I try to take my medications." So what do these care frictions mean for us as researchers and designers? While there are many best practices guidelines created for chronic illness conditions, much less attention is paid to patient behaviors that deviate from idealized ideas of engagement. While standardization is essential to ensure quality of care, it becomes increasingly obvious that not all recommendations are equally possible to achieve for people in different communities and living situations. Similarly, trying to achieve better health in practice can be a fraught, frustrating, and often frightening experience, especially if you find yourself treating a condition that can radically alter the possibilities of what healthy looks like. And even if better health, at least clinically defined, is within reach, what becomes of other equally or even more important life priorities? People have a wide range of personal preferences, family responsibilities, economic pressures, and cultural understandings of health and well-being. For many people managing chronic illness, medical treatment protocols and clinical best practices sit in constant tension with the poles of family obligations, friendship, and the good life. In CSCW and HCI, we are trained to see misalignments between stakeholders as opportunities for design intervention. However, many of the social, emotional, and environmental factors at play in patient care experiences may not be bridgeable by popular types of health technology interventions, like increased information sharing or tools for promoting health literacy. There are fundamental and routine tensions that arise from the rigid ways healthcare providers and at times designers understand best practices and how the diversity of how patients experience good care. We push back against often unquestioned assumptions of who gets to define patient-centered design. Care Frictions offers a powerful analytic lens for conceptualizing and challenging the universals of health technology design. To reimagine patient behavior beyond compliance, we can look for sticky engagements around care, noting the stressed and tired doctors, the waiting rooms full of anxious patients, chemo bodies in pain, and even communities full of spirit-led pill resistance. We see Care Frictions guiding reflection on issues like power and control, rather than providing an exhaustive list of all possible conflicts. Care Frictions make visible the wider set of relationships and activities in patient care that at first glance can seem problematic or even irrational from a strictly medical viewpoint. The technologies we study and design as CSCW researchers rarely support non-idealized patient behaviors. When patients do not conform to the expectations of the formal healthcare system, they are often viewed as non-compliant, which influences not only their relationships with clinicians, but also with technology. We are not arguing for design to support all patient behaviors. There are serious questions to consider around patient safety and well-being. However, we maintain that a necessary aspect of advancing toward more personalized, patient-centered medicine is also recognizing the breadth of patient behaviors, even non-idealized behaviors, and using these to grapple with questions including the meaning of health and well-being interventions. To this end, we encourage health researchers and designers to use research methods to capture behavioral diversity, develop strategies to support a multiplicity of patient behaviors, for instance, enabling patients to define their own goals within apps, as Munson et al. Have done in the self-tracking context, and to be reflexive as designers and researchers. Rather than immediately jumping in to reconcile tensions, Care Frictions create reflexive space to engage the very real patient experiences of needing assistance, anxiety and anger, secrecy, and creative making do. While some may approach conflicts between people and their medical worlds as an opportunity to nudge people into becoming better patients, through the lens of Care Frictions, we imagine new generative possibilities. How might patient-centered technologies change if we took the notion of uncommon goals in healthcare as a starting point? Finally, we thank our participants, our reviewers, and the prior sponsors of this research. Thank you.